Hello, nursing students. Welcome to Nursing Exam Preparation, your ultimate resource for mastering nursing exams with confidence. In today's video, we'll take you through 150 multiple-choice questions, MCQs, on hematology, each thoughtfully crafted to challenge your understanding and deepen your knowledge of this crucial topic. We provide detailed explanations after every question to ensure that you not only answer correctly, but also fully understand the reasoning behind each response. Whether you're just starting your studies or preparing for an upcoming exam, this video is packed with valuable content to test your skills, strengthen your critical thinking, and reinforce key hematology concepts. Be sure to like this video, share it with your fellow students, and subscribe to Nursing Exam Preparation for more helpful resources. Don't forget to hit the bell icon so you never miss an update on our latest videos, all designed to support your success. After finishing the video, we'd love to hear how you did. Let us know your score in the comments below. Let's get started and work together toward mastering hematology and acing your exams. 1. Which of the following blood cells is primarily responsible for oxygen transport? A. Leukocytes. B. Platelets. C. Erythrocytes. D. Monocytes. Answer: C. Erythrocytes. Rationale: erythrocytes, or red blood cells, contain hemoglobin, which binds to oxygen and transports it throughout the body. Leukocytes are part of the immune system, platelets are involved in clotting, and monocytes are a type of white blood cell that plays a role in immune defense. 2. Which condition is characterized by a decrease in the number of platelets? A. Anemia. B. Leukemia. C. Thrombocytopenia. D. Polycythemia. Answer: C. Thrombocytopenia. Rationale: thrombocytopenia is a condition where the platelet count is low, leading to increased risk of bleeding. Anemia involves a decrease in red blood cells. Leukemia is a cancer of the blood-forming tissues, and polycythemia refers to an excess of red blood cells. 3. What is the primary function of hemoglobin in red blood cells? A. Fighting infection. B. Clotting blood. C. Transporting oxygen. D. Destroying pathogens. Answer: C. Transporting oxygen. Rationale: hemoglobin binds to oxygen in the lungs and releases it in tissues throughout the body. It is not involved in infection fighting, clotting, or pathogen destruction, which are functions of the immune system and platelets. 4. Which of the following is a potential complication of untreated iron deficiency anemia? A. Hypercalcemia. B. Heart failure. C. Stroke. D. Sepsis. Answer: B. Heart failure. Rationale: untreated iron deficiency anemia leads to a reduced oxygen carrying capacity of the blood, which can strain the heart, potentially leading to heart failure. Hypercalcemia, stroke, and sepsis are not direct complications of iron deficiency anemia. 5. What is the primary site of hematopoiesis in adults? A. Liver. B. Spleen. C. Bone marrow. D. Thymus. Answer: C's bone marrow. Rationale: in adults, hematopoiesis primarily occurs in the bone marrow, where all types of blood cells are produced. The liver and spleen play a role in hematopoiesis during fetal development, and the thymus is involved in the maturation of T lymphocytes. 6. Which of the following blood tests would be most useful in diagnosing a vitamin B12 deficiency? A. Platelet count. B. Prothrombin time. C. Mean corpuscular volume, MCV. D. Hemoglobin concentration. Answer: C. Mean corpuscular volume, MCV. Rationale: a high MCV is indicative of macrocytic anemia, often due to vitamin B12 or folate deficiency. Platelet count, prothrombin time, and hemoglobin concentration are not specific for diagnosing vitamin B12 deficiency. 7. What is the role of vitamin K in the coagulation process? A. Activates platelets. B. Enhances fibrinogen production. C. Facilitates the synthesis of clotting factors. D. Inhibits clot formation. Answer: C. Facilitates the synthesis of clotting factors. Rationale: vitamin K is essential for synthesizing clotting factors 2, 7, 9, and X in the liver. It does not directly activate platelets or enhance fibrinogen production. It is also not an inhibitor of clot formation, but rather a promoter of clotting. 8. Which of the following is a hallmark sign of acute lymphoblastic leukemia? All. A. Elevated white blood cell count with immature cells. B. Low red blood cell count. C. High platelet count. D. Increased hemoglobin levels. Answer. A. Elevated white blood cell count with immature cells. Rationale. All is characterized by an elevated white blood cell count, often with immature or blast cells. Low red blood cell count and high platelet count are not typically associated with all, and increased hemoglobin is not a feature of this disease. 9. Which of the following conditions is associated with the presence of Reed-Sternberg cells? A. Hodgkin lymphoma. B. Non-Hodgkin lymphoma. C. Leukemia. D. Multiple myeloma. Answer. A. Hodgkin lymphoma. Rationale. Reed-Sternberg cells are characteristic of Hodgkin lymphoma, a type of lymphoma. Non-Hodgkin lymphoma, leukemia, and multiple myeloma do not involve Reed-Sternberg cells. 10. A patient with hemophilia A is at risk for which of the following complications? A. Thrombus formation. B. Excessive bleeding. C. Iron overload. D. Thrombocytopenia. Answer. B. Excessive bleeding. Rationale. Hemophilia A is a genetic disorder that results in a deficiency of clotting factor VIII, leading to excessive bleeding, especially after injury or surgery. Thrombus formation, iron overload, and thrombocytopenia are not typically associated with hemophilia A. 11. Which of the following is the most common cause of iron deficiency anemia in adults? A. Excessive blood loss. B. Decreased erythropoiesis. C. Vitamin B12 deficiency. D. Increased destruction of red blood cells. Answer. A. Excessive blood loss. Rationale. The most common cause of iron deficiency anemia in adults is excessive blood loss, often from gastrointestinal bleeding or heavy menstrual periods. Decreased erythropoiesis, vitamin B12 deficiency, and increased RBC destruction are not primary causes of iron deficiency. 12. Which of the following is the primary function of platelets? A. Oxygen transport. B. Immune response. C. Clot formation. D. Antibody production. Answer. C. Clot formation. Rationale. Platelets are crucial for hemostasis and blood clot formation. They aggregate at the site of blood vessel injury and form a clot. Oxygen transport is performed by erythrocytes, immune responses are carried out by leukocytes, and antibodies are produced by B cells. 13. A decrease in which of the following is most likely to be seen in a patient with sickle cell anemia? A. Hemoglobin. B. Platelet count. C. Leukocytes. D. Reticulocytes. Answer. A. Hemoglobin. Rationale. Sickle cell anemia is characterized by an abnormal form of hemoglobin S, which leads to a decrease in overall hemoglobin levels and impaired oxygen transport. Platelet count, leukocytes, and reticulocytes are not typically reduced in this condition. 14. Which of the following is a feature of polycythemia vera? A. Decreased red blood cell mass. B. Increased white blood cell count. C. Decreased hematocrit levels. D. Increased red blood cell mass. Answer. D. Increased red blood cell mass. Rationale. Polycythemia vera is a disorder characterized by an increase in red blood cell mass, leading to elevated hematocrit levels. The condition does not affect white blood cell or platelet counts in the same way. 15. What is the most common clinical manifestation of deep vein thrombosis, DVT? A. Hemoptysis. B. Warmth and swelling in the affected leg. C. Severe headache. D. Chest pain and shortness of breath. Answer. B. Warmth and swelling in the affected leg. Rationale. Deep vein thrombosis commonly presents with swelling, warmth, and tenderness in the affected leg due to the clot. Hemoptysis, severe headache, and chest pain are more commonly associated with pulmonary embolism or other conditions. 16. A patient with chronic lymphocytic leukemia, CLL, is at increased risk for which of the following? A. Anemia. B. Hypertension. C. Acute blood loss. D. Thrombocytopenia. Answer. A. Anemia. Rationale. Chronic lymphocytic leukemia, CLL, often leads to anemia due to bone marrow infiltration and decreased red blood cell production. It can also cause thrombocytopenia, but anemia is the most common hematological abnormality in CLL. 17. In which of the following conditions is the prothrombin time, PT, most likely to be prolonged? A. Iron deficiency anemia. B. Hemophilia A. C. Vitamin K deficiency. D. Polycythemia. Answer: C. Vitamin K deficiency. Rationale: vitamin K is essential for the synthesis of clotting factors, and a deficiency results in prolonged PT. Hemophilia A affects clotting factor VIII, but PT is usually normal, and iron deficiency anemia and polycythemia do not directly affect PT. 18. Which of the following blood cell types is most responsible for the body's defense against infections? A. Erythrocytes. B. Leukocytes. C. Platelets. D. Reticulocytes. Answer: B. Leukocytes. Rationale: leukocytes, white blood cells, are primarily responsible for the immune response, defending the body against infections. Erythrocytes transport oxygen, platelets aid in clotting, and reticulocytes are immature red blood cells. 19. What is the function of the spleen in relation to blood cells? A. Storage of red blood cells. B. Production of platelets. C. Destruction of old red blood cells. D. Synthesis of clotting factors. Answer: C. Destruction of old red blood cells. Rationale: the spleen filters and removes old or damaged red blood cells from circulation. It does not store red blood cells, that's the role of bone marrow, produce platelets, or synthesize clotting factors. 20. A common feature of hemolytic anemia is A. Decreased red blood cell destruction. B. Increased respiratory count. C. Elevated hematocrit. D. Increased white blood cell count. Answer: B. Increased respiratory count. Rationale: hemolytic anemia results in the premature destruction of red blood cells, which leads to an increase in reticulocytes as the bone marrow compensates by producing more red blood cells. Hematocrit is typically decreased, and WBC count is not usually elevated in this condition. 21. A patient with a history of alcohol abuse presents with signs of bleeding. Which of the following lab results would you expect to be abnormal? A. Low hemoglobin. B. Low platelet count. C. Increased hematocrit. D. Elevated respiratory count. Answer: B. Low platelet count. Rationale: alcohol abuse can lead to thrombocytopenia, low platelet count, which increases the risk of bleeding. It may also cause liver dysfunction, which can affect clotting factor synthesis, but low hemoglobin and increased hematocrit are not characteristic of alcohol-related bleeding. 22. Which of the following clotting factors is deficient in hemophilia A? A. Factor 7. B. Factor 8. C. Factor 9. D. Factor X. Answer: B. Factor 8. Rationale: hemophilia A is a genetic disorder caused by a deficiency of clotting factor 8. Hemophilia B is caused by a deficiency of factor 9. Factor 7 and X are involved in different steps of the coagulation cascade. 23. Which of the following conditions is characterized by an excess of white blood cells? A. Polycythemia. B. Leukopenia. C. Leukemia. D. Hemophilia. Answer: C. Leukemia. Rationale: leukemia is a cancer of the blood and bone marrow that results in an abnormal increase in white blood cells. Polycythemia involves an excess of red blood cells, leukopenia is a decrease in white blood cells, and hemophilia affects clotting factors. 24. What is the primary treatment for vitamin K deficiency? A. Blood transfusion. B. Administration of vitamin K. C. Platelet transfusion. D. Iron supplementation. Answer: B. Administration of vitamin K. Rationale: vitamin K deficiency is treated by administering vitamin K to restore normal clotting factor synthesis. Blood transfusions, platelet transfusions, and iron supplementation are not effective for correcting vitamin K deficiency. 25. Which of the following is most likely to cause thrombocytopenia? A. Iron deficiency. B. Acute leukemia. C. Polycythemia vera. D. Vitamin B12 deficiency. Answer: B. Acute leukemia. Rationale: acute leukemia can cause thrombocytopenia due to bone marrow infiltration and suppression of platelet production. Iron deficiency, polycythemia vera, and vitamin B12 deficiency are not typically associated with low platelet counts. 26. What is the primary mechanism of action of anticoagulants like heparin? A. Inhibit platelet aggregation. B. Activate clotting factors. C. Inhibit thrombin and factor XA. D. Promote fibrinogen production. Answer: C. Inhibit thrombin and factor XA. Rationale: heparin works by inhibiting thrombin and factor XA, which are crucial in the coagulation cascade. It does not directly affect platelet aggregation or fibrinogen production. 27. A patient with a history of atherosclerosis is at risk for which of the following? A. Excessive bleeding. B. Thrombosis. C. Sickle cell crisis. D. Polycythemia. Answer: B. Thrombosis. Rationale: atherosclerosis increases the risk of thrombosis due to the buildup of plaque in blood vessels, which can trigger clot formation. Excessive bleeding, sickle cell crisis, and polycythemia are not related to atherosclerosis. 28. What is the most likely cause of aplastic anemia? A. Autoimmune destruction of bone marrow. B. Deficiency of vitamin B12. C. Iron deficiency. D. Hemoglobin S mutation. Answer: A. Autoimmune destruction of bone marrow. Rationale: aplastic anemia is most commonly caused by autoimmune destruction of the bone marrow, leading to pancytopenia, low levels of all blood cell types. Vitamin B12 deficiency and iron deficiency cause different types of anemia, and hemoglobin S mutation causes sickle cell anemia. 29. Which of the following is a characteristic finding in a patient with chronic myelogenous leukemia, CML? A. Philadelphia chromosome. B. Reed-Sternberg cells. C. Elevated erythropoietin levels. D. Decreased white blood cell count. Answer: A. Philadelphia chromosome. Rationale: the Philadelphia chromosome is a genetic abnormality associated with chronic myelogenous leukemia, CML. Reed-Sternberg cells are associated with Hodgkin lymphoma, elevated erythropoietin levels are seen in polycythemia vera, and CML typically results in an elevated white blood cell count. 30. What is the most likely cause of hemolytic transfusion reactions? A. Iron deficiency. B. Mismatched blood transfusion. C. Vitamin B12 deficiency. D. Acute leukemia. Answer: B. Mismatched blood transfusion. Rationale: hemolytic transfusion reactions typically occur when a patient receives a blood transfusion of mismatched blood, leading to the destruction of transfused red blood cells. Iron deficiency, vitamin B12 deficiency, and acute leukemia do not directly cause transfusion reactions. 31. Which of the following is the primary cause of anemia in chronic kidney disease? A. Iron deficiency. B. Decreased erythropoietin production. C. Hemolysis. D. Vitamin B12 deficiency. Answer: B. Decreased erythropoietin production. Rationale: in chronic kidney disease, the kidney's ability to produce erythropoietin, a hormone that stimulates red blood cell production, is impaired, leading to anemia. Iron deficiency, hemolysis, and vitamin B12 deficiency are not the primary causes in this context. 32. What is the main characteristic of non-Hodgkin lymphoma, NHL? A. Presence of Reed-Sternberg cells. B. Enlargement of lymph nodes. C. Severe leukopenia. D. Infiltration of the bone marrow with blasts. Answer: B. Enlargement of lymph nodes. Rationale: non-Hodgkin lymphoma is often characterized by the enlargement of lymph nodes, which can be painless and may occur in various parts of the body. Reed-Sternberg cells are a hallmark of Hodgkin lymphoma, not NHL. 33. Which of the following conditions is associated with a deficiency in clotting factor IX? A. Hemophilia A. B. Hemophilia B. C. Von Willebrand disease. D. Vitamin K deficiency. Answer: B. Hemophilia B. Rationale: hemophilia B, also known as Christmas disease, is caused by a deficiency of clotting factor IX. Hemophilia A is caused by a deficiency of factor VIII, Von Willebrand disease affects factor VIII and platelet function, and vitamin K deficiency impacts clotting factors 2, 7, 9, and X. 34. Which blood disorder is characterized by the presence of Howell-Jolly bodies on a peripheral blood smear? A. Sickle cell anemia. B. Thalassemia. C. Post-splenectomy. D. Iron deficiency anemia. Answer: C. Post-splenectomy. Rationale: Howell-Jolly bodies are remnants of nuclear material in red blood cells and are commonly seen in patients who have had a splenectomy. Sickle cell anemia and thalassemia may cause other blood abnormalities, and iron deficiency anemia typically does not show Howell-Jolly bodies. 35. In which condition would you expect to see a shift to the left in the white blood cell count? A is acute bacterial infection. B is chronic viral infection. C. Iron deficiency anemia. D. Hemophilia. Answer: A. Acute bacterial infection. Rationale: a shift to the left refers to the presence of increased immature white blood cells, bands, in the blood, which is a common response to acute bacterial infections. Chronic viral infections typically show normal or slightly increased lymphocytes, and iron deficiency anemia and hemophilia do not involve changes in WBC count. 36. A patient with chronic myelogenous leukemia, CML, has a high white blood cell count. What is the most likely cause of this elevation? A. Increased red blood cell production. B. Infiltration of the bone marrow with malignant cells. C. Decreased platelet production. D. Autoimmune destruction of white blood cells. Answer: B. Infiltration of the bone marrow with malignant cells. Rationale: in CML, malignant myeloblasts proliferate in the bone marrow, leading to an elevated white blood cell count. It does not affect red blood cell production directly or cause autoimmune destruction of WBCs. 37. Which of the following lab tests would be most useful in monitoring the effectiveness of warfarin therapy? A. Prothrombin time, PT, and international normalized ratio, INR. B. Partial thromboplastin time, PTT. C's complete blood count, CBC. D. Liver function tests. Answer: A. Prothrombin time, PT, and international normalized ratio, INR. Rationale: warfarin therapy is monitored using PT and INR to assess the clotting ability of the blood. PTT is more useful for monitoring heparin therapy, and CBC and liver function tests are not specific to warfarin's effectiveness. 38. What is the primary treatment for hemophilia A? A. Blood transfusions. B. Factor VIII replacement therapy. C. Vitamin K supplementation. D. Iron supplementation. Answer: B. Factor VIII replacement therapy. Rationale: hemophilia A is treated with intravenous infusion of clotting factor VIII to replace the deficient factor. Blood transfusions, vitamin K, and iron supplementation are not effective in managing hemophilia A. 39. A patient is diagnosed with iron deficiency anemia. Which of the following is the most likely cause of this condition? A. Chronic blood loss. B. Bone marrow failure. C. Vitamin B12 deficiency. D. Overproduction of red blood cells. Answer: A. Chronic blood loss. Rationale: the most common cause of iron deficiency anemia is chronic blood loss, often from gastrointestinal bleeding or heavy menstrual periods. Bone marrow failure, vitamin B12 deficiency, and overproduction of RBCs do not typically cause iron deficiency. 40. A patient with sickle cell disease is at risk for which of the following complications? A. Pulmonary embolism. B. Stroke. C. Iron overload. D. Thrombocytopenia. Answer: B. Stroke. Rationale: sickle cell disease increases the risk of stroke due to the sickling of red blood cells, which can block blood flow in cerebral vessels. Pulmonary embolism, iron overload, and thrombocytopenia are not the primary complications in sickle cell disease. 41. A patient with hemolytic anemia has a respiratory count of 20%. What is the likely cause of this finding? A. Bone marrow failure. B. Increased red blood cell destruction. C. Iron deficiency. D. Vitamin B12 deficiency. Answer: B. Increased red blood cell destruction. Rationale: an elevated respiratory count indicates that the bone marrow is compensating for increased red blood cell destruction, which is characteristic of hemolytic anemia. Bone marrow failure would typically lead to a low respiratory count, and iron or vitamin B12 deficiencies do not cause such a high respiratory count. 42. Which of the following is the most common complication of transfusion-associated circulatory overload, TACO? A. Pulmonary edema. B. Hemolytic reaction. C. Anaphylaxis. D. Bacterial infection. Answer: A. Pulmonary edema. Rationale: TACO occurs when blood volume increases too rapidly, leading to pulmonary edema. Hemolytic reactions, anaphylaxis, and bacterial infections are not typical complications of TACO. 43. Which type of anemia is characterized by the production of small, hypochromic red blood cells? A. Sickle cell anemia. B. Thalassemia. C. Iron deficiency anemia. D. Pernicious anemia. Answer: C. It's iron deficiency anemia. Rationale: iron deficiency anemia results in small, hypochromic, pale, red blood cells. Thalassemia also results in microcytic red blood cells, but the underlying mechanism is different. Sickle cell anemia involves sickled cells, and pernicious anemia is characterized by macrocytic, megaloblastic cells. 44. Which of the following is the most common cause of vitamin B12 deficiency? A. Iron deficiency. B. Pernicious anemia. C. Folate deficiency. D. Chronic blood loss. Answer: B. Pernicious anemia. Rationale: pernicious anemia, which results from the lack of intrinsic factor required for vitamin B12 absorption, is the most common cause of vitamin B12 deficiency. Iron deficiency and folate deficiency cause different types of anemia, and chronic blood loss leads to iron deficiency anemia. 45. Which of the following disorders is associated with an increased risk of deep vein thrombosis, DVT? A. Hemophilia. B. Factor V Leiden mutation. C. Iron deficiency anemia. D. Von Willebrand disease. Answer: B. Factor V Leiden mutation. Rationale: Factor V Leiden is a genetic mutation that increases the risk of thrombophilia and DVT. Hemophilia, iron deficiency anemia, and von Willebrand disease do not predispose individuals to DVT in the same way. 46. In a patient with thrombocytopenia, which of the following is a major concern? A. Risk for bleeding. B. Risk for infection. C. Risk for stroke. D. Risk for blood clot formation. Answer: A. Risk for bleeding. Rationale: thrombocytopenia is characterized by a low platelet count, which increases the risk for bleeding. Infection, stroke, and blood clot formation are not primary concerns in this condition. 47. Which of the following would you expect to find in a patient with von Willebrand disease? A. Low platelet count. B. Prolonged prothrombin time, PT. C. Prolonged bleeding time. D. Low red blood cell count. Answer: C. Prolonged bleeding time. Rationale: von Willebrand disease results in a deficiency or dysfunction of von Willebrand factor, which affects platelet adhesion and results in prolonged bleeding time. PT is not typically prolonged, and red blood cell count and platelet count are usually normal. 48. A patient with leukemia is at risk for which of the following? A. Anemia. B. Polycythemia. C. Hypertension. D. Hemoconcentration. Answer: A. Anemia. Rationale: leukemia often leads to anemia due to bone marrow infiltration by malignant cells, which impairs red blood cell production. Polycythemia, hypertension, and hemoconcentration are not characteristic of leukemia. 49. Which of the following is the primary treatment for a patient with severe thrombocytopenia due to immune thrombocytopenic purpura, IDP? A. Platelet transfusion. B. Intravenous immunoglobulin, IVIG. C. Vitamin K supplementation. D. Factor VIII infusion. Answer: B. Intravenous immunoglobulin, IVIG. Rationale: IDP is treated with IVIG, which helps to suppress the immune system's destruction of platelets. Platelet transfusion may be necessary in severe cases, but IVIG is the mainstay treatment. Vitamin K and Factor VIII are not effective in ITP. 50. Which of the following lab findings is characteristic of anemia of chronic disease? A. Low ferritin levels. B. Elevated respiratory count. C. Low serum iron and low transferrin saturation. D. High vitamin B12 levels. Answer: C. Low serum iron and low transferrin saturation. Rationale: in anemia of chronic disease, serum iron and transferrin saturation are low due to inflammation, but ferritin levels are typically normal or elevated. The respiratory count is usually low, and vitamin B12 levels are not typically elevated in this condition. 51. Which of the following is the most common cause of iron deficiency anemia in infants? A. Vitamin C deficiency. B. Insufficient iron intake. C. Hemolysis. D. Increased erythropoiesis. Answer: B. Insufficient iron intake. Rationale: the most common cause of iron deficiency anemia in infants is insufficient iron intake, often due to inadequate diet or exclusive breastfeeding beyond 6 months, without iron supplementation. Vitamin C deficiency does not cause anemia, and increased erythropoiesis would not cause iron deficiency. 52. In a patient with polycythemia vera, which of the following is commonly elevated? A. Hemoglobin levels. B. Erythropoietin levels. C. Platelet count. D. Respiratory count. Answer: A. Hemoglobin levels. Rationale: polycythemia vera is characterized by an increase in red blood cell mass, leading to elevated hemoglobin and hematocrit levels. Erythropoietin levels are typically low due to the negative feedback mechanism, and platelet count can be elevated, but not as consistently. Respiratory count is usually normal or low. 53. Which of the following is a classic sign of vitamin B12 deficiency? A. Glossitis. B. Petechiae. C. Splenomegaly. D. Weight loss. Answer: A. Glossitis. Rationale: glossitis, inflammation of the tongue, is a classic sign of vitamin B12 deficiency, often along with fatigue and weakness. Petechiae are associated with thrombocytopenia. Splenomegaly is not specific to vitamin B12 deficiency, and weight loss is not a hallmark symptom. 54. A patient with a history of multiple blood transfusions is at risk for which of the following? A. Vitamin B12 deficiency. B. Iron overload. C. Folate deficiency. D. Thrombocytopenia. Answer: B. Iron overload. Rationale: multiple blood transfusions can lead to iron overload, as each transfusion introduces additional iron into the body, which can accumulate in organs like the liver, heart, and pancreas. Vitamin B12, folate deficiencies, and thrombocytopenia are not commonly caused by multiple transfusions. 55. Which of the following conditions is most likely to be associated with a prolonged partial thromboplastin time, PTT? A. Hemophilia A. B. Factor V Leiden mutation. C. Iron deficiency anemia. D. Chronic lymphocytic leukemia, CLL. Answer: A. Hemophilia A. Rationale: hemophilia A deficiency of clotting factor VIII, results in a prolonged PTT. Factor V Leiden mutation leads to a hypercoagulable state, which would not affect PTT, and iron deficiency anemia and CLL do not typically cause prolonged PTT. 56. What is the primary action of erythropoietin in the body? A. Stimulates platelet production. B. Stimulates red blood cell production. C. Stimulates white blood cell production. D. Inhibits red blood cell destruction. Answer: B. Stimulates red blood cell production. Rationale: erythropoietin, primarily produced by the kidneys, stimulates the bone marrow to produce red blood cells in response to low oxygen levels. It does not affect platelet or white blood cell production, nor does it inhibit RBC destruction. 57. Which of the following findings is typically associated with anemia caused by chronic disease? A. Low respiratory count. B. Elevated respiratory count. C. High serum iron levels. D. Increased erythropoietin levels. Answer: A. Low respiratory count. Rationale: in anemia of chronic disease, the respiratory count is typically low because the bone marrow response is blunted due to chronic inflammation. Serum iron levels are also usually low, and erythropoietin levels may be normal or inappropriately low given the degree of anemia. 58. What is the most common clinical manifestation of iron deficiency anemia? A. Shortness of breath. B. Fatigue. C. Jaundice. D. Fever. Answer: B. Fatigue. Rationale: the most common symptom of iron deficiency anemia is fatigue, as the body has inadequate hemoglobin to carry oxygen efficiently. Shortness of breath, jaundice, and fever are not primary symptoms of iron deficiency anemia. 59. Which of the following is a key laboratory finding in a patient with sickle cell anemia? A. High hemoglobin A levels. B. Elevated white blood cell count. C. Reticulocytosis. D. Low platelet count. Answer: C. Reticulocytosis. Rationale: in sickle cell anemia, reticulocytosis, increased reticulocytes, is common due to the premature destruction of red blood cells, which triggers increased RBC production. Hemoglobin A levels are low in sickle cell disease, and WBC count and platelet count are not typically elevated in the absence of infection. 60. A patient with multiple myeloma typically presents with which of the following symptoms? A. Petechiae. B. Hypercalcemia. C. Hypotension. D. Pallor. Answer: B. Hypercalcemia. Rationale: multiple myeloma is often associated with hypercalcemia due to bone resorption caused by malignant plasma cells. Petechiae are associated with thrombocytopenia. Hypotension and pallor can be seen in various conditions but are not specific to multiple myeloma. 61. Which of the following laboratory values would you expect to be elevated in a patient with disseminated intravascular coagulation (DIC? A. Platelet count. B. Prothrombin time (PT). C. Hemoglobin level. D. Respiratory count. Answer: B. Prothrombin time (PT). Rationale: in DIC, there is widespread activation of the coagulation cascade, leading to prolonged PT due to consumption of clotting factors. Platelet count is typically decreased, hemoglobin levels are not directly affected by DIC, and respiratory count is not usually elevated. 62. A patient with severe bleeding due to a deficiency in clotting factors would most likely have an abnormal A. Complete blood count, CBC. B. Liver function test. C. Coagulation profile, PT, PTT. D. Serum creatinine level. Answer: C's coagulation profile, PT, PTT. Rationale: bleeding due to a deficiency in clotting factors typically results in an abnormal coagulation profile, particularly in PT and/or PTT. CBC and liver function tests are not directly related to the deficiency of clotting factors, and serum creatinine is more relevant for renal function assessment. 63. Which of the following is the most common cause of thrombocytosis? Elevated platelet count. A. Iron deficiency anemia. B. Chronic inflammation or infection. C. Hemophilia. D. Sickle cell anemia. Answer: B. Chronic inflammation or infection. Rationale: thrombocytosis is most commonly seen in response to chronic inflammation or infection. Iron deficiency anemia may also cause secondary thrombocytosis, but chronic conditions like infection or inflammatory diseases are the most frequent cause. Hemophilia and sickle cell anemia are not associated with elevated platelet counts. 64. Which of the following is a characteristic finding in patients with pernicious anemia? A. Elevated mean corpuscular volume, MCV. B. Low platelet count. C. Increased hemoglobin levels. D. Decreased respiratory count. Answer: A. Elevated mean corpuscular volume, MCV. Rationale: pernicious anemia is characterized by the production of larger than normal red blood cells, leading to an elevated MCV. Platelet count is typically normal, hemoglobin levels are decreased, and respiratory count is also usually low due to impaired RBC production. 65. Which of the following would you expect in a patient with vitamin K deficiency? A. Prolonged bleeding time. B. Prolonged prothrombin time, PT. C. Elevated platelet count. D. Increased respiratory count. Answer: B. Prolonged prothrombin time, PT. Rationale: Vitamin K is essential for the synthesis of clotting factors 2, 7, 9, and X. A deficiency in vitamin K results in a prolonged PT due to impaired clotting factor production. Bleeding time, platelet count, and respiratory count are not typically affected by vitamin K deficiency. 66. A patient diagnosed with hemolytic anemia presents with jaundice. Which of the following is most likely responsible for this symptom? A. Increased red blood cell destruction. B. Vitamin B12 deficiency. C. Chronic kidney disease. D. Myelodysplastic syndrome. Answer: A. Increased red blood cell destruction. Rationale: jaundice in hemolytic anemia is caused by the breakdown of red blood cells, leading to increased bilirubin levels. Vitamin B12 deficiency, chronic kidney disease, and myelodysplastic syndrome are not typically associated with jaundice from hemolysis. 67. Which of the following is a potential complication of chronic sickle cell disease? A. Renal failure. B. Hypertension. C. Hyperglycemia. D. Pulmonary embolism. Answer: A. Renal failure. Rationale: chronic sickle cell disease can lead to renal failure due to glomerular damage caused by repeated vaso-occlusion and ischemia. Hypertension, hyperglycemia, and pulmonary embolism are not as directly related to sickle cell disease. 68. Which of the following lab findings is associated with acute myelogenous leukemia, AML? A. Low white blood cell count. B. Presence of Auer rods in bone marrow. C. Decreased lactate dehydrogenase, LDH. D. Elevated hemoglobin levels. Answer: B. Presence of Auer rods in bone marrow. Rationale: Auer rods are characteristic of acute myelogenous leukemia, AML, seen in myeloblasts in the bone marrow. AML is typically associated with an elevated WBC count, increased LDH, and decreased hemoglobin levels, not an elevated hemoglobin. 69. A patient with a history of hypertension and smoking is at increased risk for which of the following hematologic complications? A. Anemia. B. Deep vein thrombosis, DVT. C. Hemophilia. D. Leukemia. Answer: B. Deep vein thrombosis, DVT. Rationale: hypertension and smoking are risk factors for thrombosis, including deep vein thrombosis, DVT. Anemia, hemophilia, and leukemia are not directly associated with these lifestyle factors. 70. A patient undergoing chemotherapy is at risk for which of the following hematologic complications? A. Thrombocytosis. B. Neutropenia. C. Polycythemia. D. Hemochromatosis. Answer: B. Neutropenia. Rationale: chemotherapy can suppress bone marrow function, leading to neutropenia, a low neutrophil count, which increases the risk of infection. Thrombocytosis, polycythemia, and hemochromatosis are not typical complications of chemotherapy. 71. A patient with hemophilia presents with excessive bleeding after a minor injury. What is the primary treatment? A. Blood transfusion. B. Clotting factor replacement. C. Vitamin K administration. D. Platelet transfusion. Answer: B. Clotting factor replacement. Rationale: hemophilia is treated with the replacement of the deficient clotting factor, e.g., factor VIII for hemophilia A. Blood transfusions, vitamin K, and platelet transfusions are not the primary treatments for hemophilia. 72. A patient with chronic kidney disease is at risk for which of the following hematologic complications? A. Anemia. B. Leukopenia. C. Thrombocytosis. D. Polycythemia. Answer: A. Anemia. Rationale: chronic kidney disease, CKD, can lead to anemia due to decreased erythropoietin production, which is essential for red blood cell production. Leukopenia, thrombocytosis, and polycythemia are not typically associated with CKD. 73. Which of the following is a common manifestation of hemochromatosis? A. Jaundice. B. Skin pigmentation changes. C. Increased bleeding tendency. D. Easy bruising. Answer: B. Skin pigmentation changes. Rationale: hemochromatosis, a condition of iron overload, commonly leads to skin pigmentation changes, often described as a bronze or grayish tone. Jaundice, increased bleeding tendency, and easy bruising are not typical manifestations of this condition. 74. Which of the following would you expect in a patient with thrombocytopenia? A. Elevated white blood cell count. B. Excessive bruising and petechiae. C. Decreased hemoglobin. D. Elevated prothrombin time, PT. Answer: B. Excessive bruising and petechiae. Rationale: thrombocytopenia, low platelet count, leads to an increased risk of bleeding, resulting in bruising and petechiae. Elevated WBC count, decreased hemoglobin, and elevated PT are not directly associated with thrombocytopenia. 75. What is the most appropriate treatment for a patient with hemophilia experiencing a bleeding episode? A. Platelet transfusion. B. Fresh frozen plasma. C. Clotting factor replacement. D. Vitamin K administration. Answer: C's clotting factor replacement. Rationale: hemophilia is treated by replacing the missing clotting factor, e.g., factor 8 or 9, which is the most effective treatment during a bleeding episode. Platelet transfusion, fresh frozen plasma, and vitamin K are not the primary treatments for hemophilia. 76. Which of the following lab findings would most likely be seen in a patient with vitamin B12 deficiency? A. Low respiratory count. B. Elevated mean corpuscular volume, MCV. C. Decreased ferritin levels. D. Increased red blood cell count. Answer: B. Elevated mean corpuscular volume, MCV. Rationale: vitamin B12 deficiency leads to the production of abnormally large red blood cells, resulting in an elevated MCV. A low respiratory count may be seen, but ferritin levels are not affected by vitamin B12 deficiency. Increased RBC count is not a characteristic finding. 77. Which of the following is a hallmark feature of sickle cell disease? A. Microcytic anemia. B. Sickled red blood cells. C. Prolonged prothrombin time, PT. D. Decreased hemoglobin levels. Answer: B. Sickled red blood cells. Rationale: sickle cell disease is characterized by the presence of sickled red blood cells, which can block blood flow and cause pain and organ damage. Microcytic anemia is seen in iron deficiency anemia, and PT is not prolonged in sickle cell disease. Decreased hemoglobin levels may occur, but are not the hallmark feature. 78. What is the most common cause of secondary polycythemia? A. Chronic obstructive pulmonary disease, COPD. B. It's iron deficiency. C. Myeloproliferative disorder. D. Hemolytic anemia. Answer: A. Chronic obstructive pulmonary disease, COPD. Rationale: secondary polycythemia is most commonly caused by chronic hypoxia, such as in COPD, which stimulates increased erythropoietin production. Iron deficiency does not cause polycythemia, and myeloproliferative disorders are primary causes. Hemolytic anemia leads to decreased red blood cells. 79. Which of the following conditions can lead to a decreased platelet count? A. Iron deficiency anemia. B. Thrombotic thrombocytopenic purpura, TTP. C. Hemochromatosis. D. Vitamin B12 deficiency. Answer: B. Thrombotic thrombocytopenic purpura, TTP. Rationale: TTP is a condition that causes widespread platelet aggregation, leading to a decreased platelet count. Iron deficiency anemia, hemochromatosis, and vitamin B12 deficiency do not typically affect platelet count. 80. A patient with a history of frequent nosebleeds and easy bruising is most likely suffering from A. Hemophilia. B. Vitamin K deficiency. C. Thrombocytopenia. D. Anemia. Answer: C. Thrombocytopenia. Rationale: thrombocytopenia is characterized by easy bruising and frequent nosebleeds due to low platelet counts. Hemophilia causes bleeding but is usually associated with more severe bleeding after trauma. Vitamin K deficiency causes bleeding, but it is not primarily associated with frequent nosebleeds. 81. Which of the following lab results is consistent with anemia of chronic disease? A. Low ferritin. B. High respiratory count. C. Low serum iron and low transferrin saturation. D. High vitamin B12 levels. Answer: C. Low serum iron and low transferrin saturation. Rationale: Anemia of chronic disease is associated with low serum iron and low transferrin saturation, often due to inflammation or infection. Ferritin levels are usually normal or elevated, and the respiratory count is typically low. Vitamin B12 levels are not usually affected by chronic disease anemia. 82. In a patient with leukemia, which of the following would most likely be elevated? A. White blood cell count. B. Hemoglobin. C. Platelet count. D. Red blood cell count. Answer: A. White blood cell count. Rationale: leukemia is characterized by an abnormal increase in the number of white blood cells, which may be immature and ineffective. Hemoglobin, platelet, and red blood cell counts are usually decreased due to bone marrow infiltration. 83. A patient with aplastic anemia has which of the following characteristics? A. Elevated white blood cell count. B. Decreased red blood cell, white blood cell, and platelet counts. C. Prolonged prothrombin time, PT. D. Elevated hemoglobin levels. Answer: B. Decreased red blood cell, white blood cell, and platelet counts. Rationale: aplastic anemia results in pancytopenia, which is a decrease in red blood cells, white blood cells, and platelets due to bone marrow failure. PT may be prolonged due to a lack of clotting factor production, but elevated hemoglobin levels are not characteristic. 84. What is the treatment of choice for a patient with vitamin K deficiency? A. Clotting factor replacement. B. Platelet transfusion. C. Vitamin K supplementation. D. Iron supplementation. Answer: C. Vitamin K supplementation. Rationale: vitamin K deficiency is treated with vitamin K supplementation to restore the synthesis of clotting factors. Clotting factor replacement, platelet transfusion, and iron supplementation are not the first-line treatments for vitamin K deficiency. 85. A patient presents with fatigue, pallor, and a low red blood cell count. Which of the following additional tests would be most helpful in diagnosing the cause of anemia? A. Respiratory count. B. Platelet count. C. Liver function tests. D. Prothrombin time, PT. Answer: A. Respiratory count. Rationale: a respiratory count is useful in determining the bone marrow's response to anemia. A low respiratory count may suggest impaired RBC production, while a high count indicates increased RBC destruction. Platelet count, liver function tests, and PT are not as helpful in diagnosing anemia. 86. A patient with bleeding tendencies and prolonged PT and PTT likely has which of the following conditions? A. Vitamin K deficiency. B is iron deficiency anemia. C. Thrombocytopenia. D. Sickle cell anemia. Answer: A. Vitamin K deficiency. Rationale: vitamin K deficiency affects the synthesis of clotting factors, leading to prolonged PT and PTT. Iron deficiency anemia, thrombocytopenia, and sickle cell anemia do not typically cause prolonged PT and PTT. 87. A patient with hemophilia is at risk for which of the following? A. Decreased bleeding. B. Increased bleeding. C. Elevated white blood cell count. D. Anemia. Answer: B. Increased bleeding. Rationale: hemophilia is characterized by a deficiency in clotting factors, which increases the risk of bleeding. It does not cause an increase in white blood cell count or anemia, though severe bleeding can lead to anemia over time. 88. Which of the following is a common symptom of polycythemia vera? A. Skin pallor. B. Painful splenomegaly. C. Frequent nosebleeds. D. Weight loss. Answer: B. Painful splenomegaly. Rationale: polycythemia vera often presents with splenomegaly, which may become painful due to blood congestion. Skin pallor is more associated with anemia, and frequent nosebleeds and weight loss are not characteristic of polycythemia vera. 89. Which of the following is the most common cause of thrombosis in patients with antiphospholipid syndrome? A. Increased platelet aggregation. B. Low vitamin K levels. C. Deficiency of clotting factor V. D. Increased clotting factor 9 levels. Answer: A. Increased platelet aggregation. Rationale: antiphospholipid syndrome is characterized by an increased tendency for thrombosis, primarily due to increased platelet aggregation and clot formation. Vitamin K deficiency, clotting factor V deficiency, and elevated factor IX levels are not the main mechanisms involved in this syndrome. 90. A patient with chronic leukemia often presents with A. Severe anemia and fatigue. B. Increased risk of infection. C. Low white blood cell count. D. Hypercalcemia. Answer: B. Increased risk of infection. Rationale: chronic leukemia results in the production of immature and ineffective white blood cells, increasing the risk of infection. Severe anemia and fatigue are common in leukemia, but the primary concern is the increased susceptibility to infections. 91. Which of the following is a potential complication of untreated pernicious anemia? A. Neurological damage. B. Thrombocytosis. C. Leukopenia. D. Jaundice. Answer: A. Neurological damage. Rationale: untreated pernicious anemia can lead to irreversible neurological damage, including peripheral neuropathy, due to vitamin B12 deficiency. Thrombocytosis, leukopenia, and jaundice are not common complications. 92. A patient with multiple myeloma often presents with which of the following lab findings? A. Elevated calcium levels. B. Decreased white blood cell count. C. Decreased hemoglobin levels. D. Elevated red blood cell count. Answer: A. Elevated calcium levels. Rationale: multiple myeloma is often associated with hypercalcemia due to bone resorption caused by malignant plasma cells. Hemoglobin levels are usually decreased, and RBC count is not elevated. White blood cell count is also often decreased. 93. What is the primary cause of anemia in a patient with chronic kidney disease? A. Iron deficiency. B. Decreased erythropoietin production. C. Hemolysis. D. Acute blood loss. Answer: B. Decreased erythropoietin production. Rationale: in chronic kidney disease, the kidneys are unable to produce sufficient erythropoietin, which leads to reduced red blood cell production and anemia. Iron deficiency, hemolysis, and acute blood loss are not the primary causes. 94. A patient with polycythemia vera is likely to present with A. Pale skin. B. Weight gain. C. Headaches and dizziness. D. Increased bleeding. Answer: C. Headaches and dizziness. Rationale: polycythemia vera leads to increased red blood cell mass and blood viscosity, which can cause headaches, dizziness, and a sensation of fullness in the head. Pale skin is typical in anemia, while increased bleeding is less common in polycythemia vera. 95. What is the primary treatment for an acute iron overdose? A. Vitamin C administration. B. Chelation therapy with deferoxamine. C. Activated charcoal. D. Blood transfusion. Answer: B. Chelation therapy with deferoxamine. Rationale: chelation therapy with deferoxamine is the primary treatment for acute iron overdose as it binds excess iron and facilitates its excretion. Vitamin C, activated charcoal, and blood transfusion are not first-line treatments for iron overdose. 96. Which of the following is characteristic of hemolytic anemia? A. High respiratory count. B. Decreased respiratory count. C. Low white blood cell count. D. Elevated erythropoietin levels. Answer: A. High respiratory count. Rationale: hemolytic anemia leads to the rapid destruction of red blood cells, which stimulates the bone marrow to produce more reticulocytes, resulting in an elevated respiratory count. A decreased respiratory count is more typical of anemia caused by bone marrow failure. 97. A 25-year-old woman with heavy menstrual periods is diagnosed with iron deficiency anemia. What is the most likely cause of her anemia? A. Decreased iron intake. B. Blood loss due to menstruation. C. Chronic kidney disease. D. Bone marrow failure. Answer: B. Blood loss due to menstruation. Rationale: heavy menstrual periods are a common cause of iron deficiency anemia in women, as they lead to chronic blood loss. Decreased iron intake, chronic kidney disease, and bone marrow failure are less likely causes in this case. 98. Which of the following is a potential complication of untreated sickle cell disease? A. Pulmonary embolism. B. Stroke. C. Iron deficiency anemia. D. Leukopenia. Answer: B. Stroke. Rationale: sickle cell disease increases the risk of stroke due to the obstruction of blood flow by sickled red blood cells. Pulmonary embolism, iron deficiency anemia, and leukopenia are not as directly related to sickle cell disease. 99. What is the most common cause of vitamin B12 deficiency in the elderly? A. Inadequate dietary intake. B. Malabsorption due to atrophic gastritis. C. Increased vitamin B12 excretion. D. Increased red blood cell destruction. Answer: B. Malabsorption due to atrophic gastritis. Rationale: in the elderly, the most common cause of vitamin B12 deficiency is malabsorption due to atrophic gastritis, which impairs the production of intrinsic factor necessary for B12 absorption. Inadequate dietary intake is less common in this population. 100. A patient with disseminated intravascular coagulation, DIC, would most likely exhibit A. Increased platelet count. B. Prolonged PT and PTT. C. Hyperkalemia. D. Leukocytosis. Answer: B. Prolonged PT and PTT. Rationale: DIC results in widespread clotting and fibrinolysis, leading to prolonged prothrombin time, PT, and partial thromboplastin time, PTT. Platelet count is typically low, and hyperkalemia and leukocytosis are not characteristic of DIC. 101. What is the treatment for vitamin B12 deficiency anemia? A. Blood transfusion. B. Intramuscular vitamin B12 injections. C. Iron supplementation. D. Platelet transfusion. Answer: B. Intramuscular vitamin B12 injections. Rationale: the treatment for vitamin B12 deficiency anemia is vitamin B12 supplementation, typically given intramuscularly. Blood transfusion, iron supplementation, and platelet transfusion are not effective for this type of anemia. 102. A patient with leukemia is likely to have which of the following lab results? A. Low white blood cell count. B. Low red blood cell count and platelet count. C. Elevated hemoglobin. D. Increased respiratory count. Answer: B. Low red blood cell count and platelet count. Rationale: leukemia often causes bone marrow suppression, leading to low red blood cell and platelet counts and potentially high white blood cell counts with abnormal cells. Hemoglobin and respiratory counts are typically decreased. 103. What is the primary function of erythropoietin? A. Stimulate platelet production. B. Stimulate red blood cell production. C. Regulate iron metabolism. D. Increase white blood cell production. Answer: B. Stimulate red blood cell production. Rationale: erythropoietin is a hormone produced primarily by the kidneys that stimulates the production of red blood cells in the bone marrow. It does not affect platelet, white blood cell production, or iron metabolism. 104. Which of the following is a common manifestation of hemophilia? A. Easy bruising and excessive bleeding after injury. B. Pallor and fatigue. C. Shortness of breath and chest pain. D. Bone pain and fractures. Answer: A. Easy bruising and excessive bleeding after injury. Rationale: hemophilia is a bleeding disorder that results in difficulty forming blood clots, leading to easy bruising and excessive bleeding after trauma. Pallor, fatigue, shortness of breath, and bone pain are not typical manifestations. 105. A patient with a history of frequent blood clots is diagnosed with antiphospholipid syndrome. What is the most likely treatment? A. Antiplatelet therapy. B. Anticoagulation with warfarin. C. Clotting factor replacement. D. Platelet transfusion. Answer: B. Anticoagulation with warfarin. Rationale: antiphospholipid syndrome is typically treated with anticoagulation therapy, such as warfarin, to prevent thrombosis. Antiplatelet therapy, clotting factor replacement, and platelet transfusion are not standard treatments for this condition. 106. What is the most common cause of leukopenia in a patient undergoing chemotherapy? A. Bone marrow suppression. B. Autoimmune destruction of white blood cells. C. Infection. D. Vitamin B12 deficiency. Answer: A. Bone marrow suppression. Rationale: chemotherapy targets rapidly dividing cells, including those in the bone marrow, leading to bone marrow suppression and a decreased white blood cell count, leukopenia. Infection and vitamin B12 deficiency may also affect leukocyte count but are not the most common causes in this context. 107. A patient with a history of alcohol abuse is likely to have which of the following hematologic issues? A. Iron deficiency anemia. B. Macrocytic anemia. C. Sickle cell anemia. D. Polycythemia vera. Answer: B. Macrocytic anemia. Rationale: chronic alcohol abuse can lead to macrocytic anemia, often due to folate deficiency or liver dysfunction. Iron deficiency anemia and polycythemia vera are less likely, and sickle cell anemia is a genetic disorder unrelated to alcohol consumption. 108. A patient with a history of recent surgery presents with a deep vein thrombosis, DVT. What is the most likely cause? A. Platelet deficiency. B. Immobility and endothelial injury. C. Hemophilia. D. Sickle cell disease. Answer: B. Immobility and endothelial injury. Rationale: the most common cause of DVT after surgery is immobility and endothelial injury, which predisposes the patient to clot formation. Platelet deficiency, hemophilia, and sickle cell disease are less commonly associated with DVT in this context. 109. Which of the following would you expect to be elevated in a patient with polycythemia vera? A. Hemoglobin levels. B. White blood cell count. C. Platelet count. D. All of the above. Answer: D. All of the above. Rationale: polycythemia vera results in increased production of red blood cells, white blood cells, and platelets, leading to elevated hemoglobin, white blood cell count, and platelet count. 110. What is a common complication of untreated iron deficiency anemia? A. Heart failure. B. Stroke. C. Bone marrow failure. D. Hypercalcemia. Answer: A. Heart failure. Rationale: untreated iron deficiency anemia can lead to heart failure due to the heart working harder to compensate for the reduced oxygen-carrying capacity of the blood. Stroke, bone marrow failure, and hypercalcemia are not common complications of iron deficiency anemia. 111. A patient is diagnosed with disseminated intravascular coagulation, DIC. What is the priority nursing intervention? A. Administer anticoagulants. B. Monitor for signs of bleeding. C. Prepare for a platelet transfusion. D. Administer vitamin K. Answer: B. Monitor for signs of bleeding. Rationale: the priority in DIC is to monitor for signs of bleeding, as it can lead to severe hemorrhage. Anticoagulants, platelet transfusions, and vitamin K are not the first interventions in DIC. 112. A patient with a history of chronic alcoholism presents with symptoms of anemia. What would you expect to find on a blood smear? A. Microcytic, hypochromic red blood cells. B. Macrocytic, normochromic red blood cells. C. Sickle-shaped red blood cells. D. Increased platelet aggregation. Answer: B. Macrocytic, normochromic red blood cells. Rationale: chronic alcohol use can lead to macrocytic anemia due to folate deficiency or liver dysfunction. Microcytic anemia is characteristic of iron deficiency anemia, and sickle-shaped cells are seen in sickle cell anemia. 113. What lab result is characteristic of vitamin B12 deficiency anemia? A. Low mean corpuscular volume, MCV. B. High mean corpuscular volume, MCV. C. Elevated ferritin. D. Elevated respiratory count. Answer: B. High mean corpuscular volume, MCV. Rationale: vitamin B12 deficiency anemia is characterized by macrocytic anemia, which is reflected by a high MCV. Low MCV is characteristic of iron deficiency anemia, and elevated ferritin is typically seen in anemia of chronic disease. 114. What is the primary characteristic of thrombocytosis? A. Increased platelet count. B. Increased red blood cell count. C. Decreased white blood cell count. D. Decreased platelet count. Answer: A. Increased platelet count. Rationale: thrombocytosis is characterized by an elevated platelet count, which can increase the risk of clot formation. It does not involve increases in red blood cell count, white blood cell count, or a decrease in platelet count. 115. Which of the following is a complication of untreated chronic anemia? A. Hypertension. B. Heart failure. C. Polycythemia. D. Hemophilia. Answer: B. Heart failure. Rationale: chronic anemia increases the workload of the heart, eventually leading to heart failure due to the heart's inability to compensate for decreased oxygen delivery to tissues. Hypertension, polycythemia, and hemophilia are not complications of chronic anemia. 116. What is the primary function of platelets in hemostasis? A. To carry oxygen to tissues. B. To form a blood clot by aggregating at the site of injury. C. To destroy bacteria. D. To produce red blood cells. Answer: B. To form a blood clot by aggregating at the site of injury. Rationale: platelets play a key role in hemostasis by aggregating at the site of vascular injury and forming a clot to stop bleeding. They do not carry oxygen, destroy bacteria, or produce red blood cells. 117. A patient is diagnosed with vitamin K deficiency. What is the expected outcome in coagulation? A. Increased bleeding time due to impaired clotting factor activation. B. Increased clotting factors leading to hypercoagulability. C. Decreased platelet function leading to thrombocytopenia. D. Increased red blood cell destruction. Answer: A. Increased bleeding time due to impaired clotting factor activation. Rationale: vitamin K is essential for the activation of clotting factors, and a deficiency can lead to increased bleeding time and difficulty forming clots. It does not cause thrombocytopenia or increased red blood cell destruction. 118. A patient with sickle cell anemia is at risk for which of the following? A. Iron deficiency anemia. B. Acute pain episodes due to vaso-occlusion. C. Vitamin B12 deficiency. D. Hypercoagulability. Answer: B. Acute pain episodes due to vaso-occlusion. Rationale: sickle cell anemia causes the red blood cells to become sickle-shaped, leading to blockages in small blood vessels and resulting in painful episodes. Iron deficiency, vitamin B12 deficiency, and hypercoagulability are not typical complications of sickle cell anemia. 119. What is the primary cause of anemia in chronic kidney disease? A. Decreased erythropoietin production. B. It's iron deficiency. C. Increased red blood cell destruction. D. Acute blood loss. Answer: A. Decreased erythropoietin production. Rationale: in chronic kidney disease, the kidneys produce less erythropoietin, which is necessary for stimulating red blood cell production, leading to anemia. Iron deficiency and blood loss are not the primary causes in this context. 120. A patient with polycythemia vera is at risk for which of the following complications? A. Increased bleeding. B. Stroke. C. Iron deficiency. D. Sickle cell crisis. Answer: B. Stroke. Rationale: polycythemia vera increases the viscosity of the blood, which increases the risk of clot formation and stroke. It does not increase bleeding, cause iron deficiency, or lead to sickle cell crises. 121. A patient presents with fatigue, pallor, and glossitis. Laboratory findings show low serum B12 levels. What is the most likely diagnosis? A. Iron deficiency anemia. B. Pernicious anemia. C. Sickle cell anemia. D. Thalassemia. Answer: B. Pernicious anemia. Rationale: pernicious anemia is caused by vitamin B12 deficiency, leading to fatigue, pallor, glossitis, and neurological symptoms. Iron deficiency anemia and thalassemia present with different clinical features, while sickle cell anemia presents with pain crises and vaso-occlusion. 122. Which of the following is true regarding hemophilia? A. It is caused by a deficiency of factor IX. B. It is inherited in an autosomal dominant manner. C. It results in impaired clot formation due to a deficiency of factor VIII. D. It leads to an increased risk of deep vein thrombosis. Answer: C. It results in impaired clot formation due to a deficiency of factor VIII. Rationale: hemophilia A is an X-linked recessive disorder caused by a deficiency of clotting factor VIII, leading to impaired clot formation. It is not related to factor IX deficiency, autosomal inheritance, or deep vein thrombosis. 123. What is the most likely cause of iron deficiency anemia in an elderly patient? A. Chronic blood loss, especially from gastrointestinal bleeding. B. Vitamin B12 deficiency. C. Folic acid deficiency. D. Acute blood loss. Answer: A. Chronic blood loss, especially from gastrointestinal bleeding. Rationale: chronic blood loss from gastrointestinal bleeding is the most common cause of iron deficiency anemia in the elderly. Vitamin B12 and folic acid deficiencies can cause different types of anemia, but are not the most common causes in this population. 124. Which of the following laboratory findings is characteristic of anemia of chronic disease? A. Elevated iron levels. B. Low respiratory count. C. Elevated ferritin levels. D. Elevated mean corpuscular volume, MCV. Answer: C. Elevated ferritin levels. Rationale: in anemia of chronic disease, ferritin levels are elevated as part of the body's response to inflammation. Iron levels are typically low, and MCV is normal or low. Respiratory count is also often low. 125. A patient with a history of DVT is prescribed warfarin. What is the primary goal of warfarin therapy in this patient? A. To decrease the number of platelets. B. To prevent further clot formation. C. To dissolve existing blood clots. D. To increase the production of clotting factors. Answer: B. To prevent further clot formation. Rationale: warfarin is an anticoagulant that works by inhibiting the synthesis of vitamin K-dependent clotting factors, thus preventing further clot formation. It does not directly dissolve clots or affect platelet numbers. 126. What is the characteristic finding in a peripheral blood smear of a patient with iron deficiency anemia? A. Microcytic, hypochromic red blood cells. B. Macrocytic, normochromic red blood cells. C. Sickle-shaped red blood cells. D. Large, irregular platelets. Answer: A. Microcytic, hypochromic red blood cells. Rationale: iron deficiency anemia typically presents with microcytic, small, and hypochromic, pale, red blood cells due to a lack of hemoglobin production. Macrocytic cells are seen in vitamin B12 or folate deficiency. 127. Which of the following is a potential complication of untreated vitamin B12 deficiency anemia? A. Heart failure. B. Neurological damage, including peripheral neuropathy. C. Hypotension. D. Hypercoagulability. Answer: B. Neurological damage, including peripheral neuropathy. Rationale: untreated vitamin B12 deficiency can lead to irreversible neurological damage, such as peripheral neuropathy. It does not typically cause heart failure, hypotension, or hypercoagulability. 128. Which of the following is a common complication of acute myeloid leukemia, AML? A. Thrombosis. B. Severe bleeding due to platelet dysfunction. C. Increased red blood cell count. D. Iron overload. Answer: B. Severe bleeding due to platelet dysfunction. Rationale: AML often results in bone marrow suppression, leading to thrombocytopenia and platelet dysfunction, which increases the risk of bleeding. Thrombosis, increased red blood cell count, and iron overload are not common complications of AML. 129. A patient with hemolytic anemia has elevated levels of indirect bilirubin. What does this indicate? A. Increased red blood cell destruction. B. Impaired liver function. C. Vitamin B12 deficiency. D. Decreased red blood cell production. Answer: A. Increased red blood cell destruction. Rationale: elevated indirect bilirubin is a result of increased red blood cell destruction, as the heme portion of hemoglobin is broken down into bilirubin. Impaired liver function, vitamin B12 deficiency, and decreased red blood cell production are not the primary causes. 130. Which of the following is a feature of chronic myelogenous leukemia, CML? A. Low white blood cell count. B. Presence of the Philadelphia chromosome. C. Thrombocytopenia. D. Anemia due to iron deficiency. Answer: B. Presence of the Philadelphia chromosome. Rationale: CML is characterized by the presence of the Philadelphia chromosome, a genetic abnormality that results in the formation of the BCR-ABL fusion gene. The disease is marked by elevated white blood cell counts, not low counts. Thrombocytopenia and iron deficiency anemia are not typical features of CML. 131. What is the most common cause of acquired thrombophilia? A. Antiphospholipid syndrome. B. Factor V Leiden mutation. C. Protein C deficiency. D. Heparin-induced thrombocytopenia. Answer: A. Antiphospholipid syndrome. Rationale: antiphospholipid syndrome is the most common acquired cause of thrombophilia, leading to an increased risk of thrombosis. Factor V Leiden mutation, protein C deficiency, and heparin-induced thrombocytopenia are inherited or drug-induced causes. 132. A patient is experiencing frequent bruising and prolonged bleeding. Laboratory results show a prolonged PT and PTT. What condition is most likely? A. Hemophilia. B. Vitamin K deficiency. C. Iron deficiency anemia. D. Sickle cell anemia. Answer: B. Vitamin K deficiency. Rationale: vitamin K deficiency impairs the activation of clotting factors, leading to prolonged PT and PTT. Hemophilia is usually associated with normal PT and prolonged PTT, but it is due to a specific factor deficiency. 133. Which of the following is a characteristic feature of Hodgkin lymphoma? A. Presence of Reed-Sternberg cells. B. Bone pain. C. Low white blood cell count. D. Hypercalcemia. Answer: A. Presence of Reed-Sternberg cells. Rationale: Hodgkin lymphoma is characterized by the presence of Reed-Sternberg cells in the lymph nodes. Bone pain, low white blood cell count, and hypercalcemia are not typical features of Hodgkin lymphoma. 134. A patient with leukemia is likely to experience which of the following complications due to bone marrow suppression? A. Anemia. B. Hypertension. C. Hyperglycemia. D. Hyperkalemia. Answer: A. Anemia. Rationale: leukemia causes bone marrow suppression, leading to a decrease in the production of red blood cells, which results in anemia. It does not directly cause hypertension, hyperglycemia, or hyperkalemia. 135. A patient with a history of deep vein thrombosis, DVT, is started on anticoagulation therapy with warfarin. Which of the following is the most important lab value to monitor regularly during warfarin therapy? A. Platelet count. B. Prothrombin time, PT, and international normalized ratio, INR. C. Hemoglobin and hematocrit. D. Respiratory count. Answer: B. Prothrombin time, PT, and international normalized ratio, INR. Rationale: warfarin therapy is monitored using PT and INR to assess the effectiveness and safety of anticoagulation. Platelet count, hemoglobin, and respiratory count are not the primary monitoring parameters for warfarin therapy. 136. A patient with chronic anemia is found to have a serum ferritin level of 12 nanograms per milliliter, normal, 30 to 300 nanograms per milliliter. What is the most likely diagnosis? A. Iron deficiency anemia. B. Anemia of chronic disease. C. Sickle cell anemia. D. Vitamin B12 deficiency. Answer: A. Iron deficiency anemia. Rationale: low serum ferritin is indicative of iron deficiency anemia, as ferritin is the body's primary iron storage protein. Anemia of chronic disease typically has normal or elevated ferritin levels. 137. A patient with hemophilia A is undergoing dental surgery. What is the most important preoperative measure? A. Administering a platelet transfusion. B. Administering factor VIII replacement therapy. C. Administering vitamin K. D. Administering heparin. Answer: B. Administering factor VIII replacement therapy. Rationale: hemophilia A is due to a deficiency in factor VIII, so replacement therapy is required to ensure adequate clotting during surgery. Platelet transfusions, vitamin K, and heparin are not appropriate treatments for hemophilia A. 138. A patient presents with pallor, fatigue, and a red, smooth tongue. Laboratory tests show a low MCV, low ferritin, and high total iron binding capacity, TIBC. What is the most likely diagnosis? A. Iron deficiency anemia. B. Pernicious anemia. C. Sickle cell anemia. D. Thalassemia. Answer: A. Iron deficiency anemia. Rationale: The symptoms and laboratory findings, low MCV, low ferritin, and high TIBC, suggest iron deficiency anemia, which commonly causes pallor, fatigue, and glossitis. Pernicious anemia and sickle cell anemia have different clinical presentations and lab results. 139. Which of the following findings is most likely to be seen in a patient with chronic myelogenous leukemia, CML? A. Decreased white blood cell count. B. Presence of the Philadelphia chromosome. C. Increased red blood cell count. D. Low platelet count. Answer. B. Presence of the Philadelphia chromosome. Rationale. CML is characterized by the presence of the Philadelphia chromosome, a genetic abnormality resulting in the BCR-ABL fusion gene. White blood cell count is usually elevated, not decreased. 140. A patient with a history of recurrent nosebleeds and easy bruising is found to have a platelet count of 40,000/L, normal. 150,000-450,000/L. What is the most likely diagnosis? A. Idiopathic thrombocytopenic purpura, ITP. B. Hemophilia A. C. Vitamin K deficiency. D. Thalassemia. Answer. A. Idiopathic thrombocytopenic purpura, IDP. Rationale. IDP is an autoimmune disorder that results in a low platelet count and increased bleeding tendency, as seen in this patient. Hemophilia A affects clotting factors, not platelet count. 141. A patient with sickle cell disease is admitted with acute chest syndrome. Which of the following is the most appropriate initial management? A. Blood transfusion. B. Anticoagulation therapy. C. Iron supplementation. D. Antibiotics and oxygen therapy. Answer. D. Antibiotics and oxygen therapy. Rationale. Acute chest syndrome in sickle cell disease is treated with oxygen therapy and antibiotics to manage potential infections. Blood transfusion may be required later, but the initial approach includes oxygen and antibiotics. 142. A 45-year-old woman presents with fatigue, bruising, and an elevated white blood cell count. A bone marrow biopsy reveals an increased number of blast cells. What is the most likely diagnosis? A. Acute lymphoblastic leukemia. B. Chronic myelogenous leukemia. C. Acute myelogenous leukemia. D. Iron deficiency anemia. Answer. C. Acute myelogenous leukemia. Rationale. Acute myelogenous leukemia, AML, is characterized by an elevated white blood cell count, fatigue, bruising, and the presence of blast cells in the bone marrow. Acute lymphoblastic leukemia, ALL, typically affects children, and chronic myelogenous leukemia, CML, has a different presentation. 143. A patient with leukemia presents with fever, chills, and a sore throat. Laboratory tests reveal a white blood cell count of 10,000/L with a predominance of immature cells. What complication is most likely? A. Leukostasis. B. Infection due to neutropenia. C. Vitamin K deficiency. D. Acute myocardial infarction. Answer. B. Infection due to neutropenia. Rationale. Leukemia can lead to neutropenia due to bone marrow suppression, which increases the risk of infection. Leukostasis is a concern in very high white blood cell counts, but it is not the most likely cause of this patient's symptoms. 144. What is the primary treatment for vitamin B12 deficiency anemia? A. Oral iron supplements. B. Intramuscular vitamin B12 injections. C. Blood transfusion. D. Erythropoietin injections. Answer. B. Intramuscular vitamin B12 injections. Rationale. Vitamin B12 deficiency anemia is treated with vitamin B12 supplementation, typically via intramuscular injections. Oral iron and erythropoietin are not effective for B12 deficiency. Blood transfusion is not the primary treatment unless the patient is severely anemic. 145. A 25-year-old woman with a history of heavy menstrual periods presents with fatigue and pallor. Laboratory findings show low hemoglobin, low hematocrit, and low ferritin. What is the most likely diagnosis? A. Iron deficiency anemia due to blood loss. B. Vitamin B12 deficiency anemia. C. Sickle cell anemia. D. Thalassemia. Answer: A. Iron deficiency anemia due to blood loss. Rationale: heavy menstrual bleeding is a common cause of iron deficiency anemia in women, leading to low hemoglobin, hematocrit, and ferritin. Vitamin B12 deficiency anemia has different lab findings, and sickle cell and thalassemia present differently. 146. Which of the following is a key feature of vitamin K deficiency? A. Prolonged PT and PTT. B. Elevated white blood cell count. C. Decreased hemoglobin levels. D. Low platelet count. Answer: A. Prolonged PT and PTT. Rationale: vitamin K is essential for the activation of clotting factors. A deficiency leads to prolonged PT and PTT due to impaired clotting factor activation. It does not affect white blood cells, hemoglobin, or platelets directly. 147. Which of the following lab findings is most consistent with a diagnosis of anemia of chronic disease? A. High ferritin levels. B. High MCV. C. Low respiratory count. D. Low serum iron levels. Answer: A. High ferritin levels. Rationale: in anemia of chronic disease, ferritin levels are typically elevated due to the body's response to inflammation. Serum iron is usually low, and MCV may be normal or low, not high. 148. A 65-year-old patient presents with a history of persistent fatigue, pallor, and frequent infections. Lab tests show leukopenia and thrombocytopenia. What is the most likely diagnosis? A. Acute myelogenous leukemia. B. Iron deficiency anemia. C. Chronic lymphocytic leukemia. D. Multiple myeloma. Answer: A. Acute myelogenous leukemia. Rationale: leukopenia and thrombocytopenia in conjunction with fatigue and pallor suggest acute myelogenous leukemia, AML, a bone marrow malignancy that impairs blood cell production. Iron deficiency anemia does not cause leukopenia, and CLL and multiple myeloma present differently. 149. A patient with thrombocytopenia and easy bruising is found to have a platelet count of 20,000/L, normal. 150,000-450,000/L. What is the most likely cause? A. Vitamin K deficiency. B. Idiopathic thrombocytopenic purpura, IDP. C. Hemophilia A. D. Chronic myelogenous leukemia. Answer: B. Idiopathic thrombocytopenic purpura, IDP. Rationale: IDP is an autoimmune disorder that results in a low platelet count, leading to easy bruising and bleeding. Hemophilia A affects clotting factors, not platelet count, and CML presents with elevated white blood cell counts. 150. Which of the following is a characteristic feature of multiple myeloma? A. Increased red blood cell production. B. Presence of monoclonal protein in the urine. C. Decreased calcium levels. D. Low white blood cell count. Answer: B. Presence of monoclonal protein in the urine. Rationale: multiple myeloma is characterized by the production of monoclonal proteins, and proteins, which can be detected in the urine, Bence-Jones proteins. It also leads to increased calcium levels, not decreased, and elevated white blood cell count.